Hello everyone and welcome again. So continuing our discussion about the orthopedics trauma basic principles class, and after we talked about the fracture treatment, now we are going to talk about the fracture complications. And here we will start with the compartment syndrome. So this is probably the most important lecture in this series, because the compartment syndrome is a very significant condition. It might end up with the patient losing one of their limbs, and that's very significant and devastating to the patient and to the hospital. So it is important for you to be able to diagnose it and understand it well. Even as a junior doctor, you have to be able to diagnose it, because you will be the first line that suspect this condition, and so you have to be able to diagnose it well. And this video is going to be about that. Now I put here casts and splints in the pictures, because those are one of the most important risk factors for the compartment syndrome, and we will know why in the next slides. So in this video you will learn about definition for the compartment syndrome, then the pathophysiology, and then the causes, clinical features, treatment, and leg fasciotomy. So let's start. So let's start with the definition for the compartment syndrome. So the compartment syndrome is muscle swelling within a fascial compartment. Now the fascial compartment is a group of muscles and vessels and nerves that are surrounded by fascia. So it is muscle swelling within the fascia, resulting in increase in intracompartmental pressure and tissue hypoperfusion, because the pressure is going to obstruct the capillaries that give blood to the muscles. So when the pressure increases, the capillaries would be blocked, and because of the pressure, and this would lead to tissue hypoperfusion. Now, why muscle swell? Well, muscles swell because of the damage caused by trauma, which lead to the inflammation process. So basically, the swelling coming from the fracture and the trauma caused to the muscles. Now here we have a drawing for a muscle, and as we can see here, this is a swollen muscle because of the trauma that occurred to the muscle, and it would cause a pressure on the surrounding tissue. And if the compartment syndrome left untreated, ischemia and tissue necrosis occur, and debridement procedures has to be done, and limb amputation may be needed. Now let's talk about the pathophysiology of the compartment syndrome. So it all starts with muscle and soft tissue damage in arm or leg after trauma give rise to edema or inflammation. So muscle damage gives rise to edema and inflammation, and this will increase the pressure within one of the fascial compartments, and as we mentioned, this would block the capillaries, so it would reduce the capillary flow and muscle ischemia. And this would lead to further edema, because remember, ischemia is also damage to the muscle, so it would lead to further edema and more pressure, more ischemia, and it's a vicious cycle. And after 6 hours, necrosis of nerve and muscles within the compartment starts. So you have to take action within the 6 hours, so you save the patient limb. Nerve capable of regeneration, but muscle once infarcted is replaced by fibrous tissue. So you have to act within the 6 hours we mentioned. Causes of compartment syndrome, there is many. The number one being fractures, then the blunt injuries, the burns, the hemorrhage into compartment, especially patient taking anticoagulant, reperfusion injury following a period of limb ischemia. So basically everything that causes damage to the muscle, it will lead to the compartment syndrome. Also, emergency casting of a fracture using a tight cast. Now, when you cast the patient limb, the cast prevents the limb from swelling, and this would lead to, even if the limb swells a little bit, this would also block the capillary flow and it would lead to compartment syndrome. So emergency casting is another cause. Now we have some high-risk injuries for the compartment syndrome. So whenever you see one of those, you always look for the compartment syndrome in the patient when you follow them up. So the high-risk injuries include the fractures of the elbow, the forearm fractures, the proximal third of the tibia, the multiple fractures of the hand or foot, the crush injuries, the circumferential burns, because remember burns cause injury to the muscles too, and operations, example internal fixation, because this operation would lead to a lot of soft tissue damage, and infection too. Now for the clinical features of the compartment syndrome. So we have the classic clinical features are the 5 P's: the pain, the pallor, the paresthesia, the paralysis, and the pulselessness. So we all know the pain and pallor, but the paresthesia means the sensory dysfunction, and the paralysis means the motor dysfunction. So basically, the limb with the compartment syndrome would have paresthesia and paralysis, but not always. And pulselessness means the distal pulses are absent. So the earliest feature is the severe pain, and it may be the only feature available. The patient feels tightness of the limb and it is about to burst. So basically they describe you, the patient describes you that their limb is tight and it's about to burst. So the ischemia mostly occur on the capillary level, so pulses may still be felt and the skin is not pale. So it is not reliable for diagnosis. So basically the distal pulses, if you still feel them, they are not reliable for diagnosis because it might the ischemia on the capillary level. Paralysis, on the other hand, which is motor dysfunction and paresthesia sensory dysfunction, may occur and should be repeatedly checked for, and they are also not reliable for diagnosis, but we still check them, same as with the pulses. Pain on passive stretching of the muscles within the affected compartment, because ischemic muscles are highly sensitive to stretch. So active extension of the toes lead to increased pain in the calf. So basically the muscle with the compartment syndrome, or the ischemic muscle, when you stretch it, it would be very painful to the patient. So if you suspect the compartment syndrome, try to do active extension of the toes or flexion, or if it is in the forearm, you do the fingers, and this would increase the pain. If that's positive, then this would suggest compartment syndrome. Diagnosis is supported by measuring of the intra-compartment pressure. Split pressure cath is inserted into the compartment and pressure is measured close to the level of the fracture. Differential pressure is the difference between the diastolic pressure and the compartment pressure. So you basically calculate the compartment pressure and then you find the differential pressure, which is the difference between the diastolic and the compartment pressure. And if it is less than 30, then it's an indication for immediate compartment decompression. So the diagnosis is mainly clinical. Pressure calculation is supportive for you, and immediate open fasciotomy is done if there is high clinical suspicion, even if the pressure difference more than 30. So if the pressure difference is less than 30, then it's an immediate open fasciotomy. But if it is more than 30, the procedure is still done if there is high clinical suspicion. Now for the treatment, the compartment syndrome is a surgical emergency. The threatened compartment should be decompressed and the casts, bandages, dressings must be removed to allow the limb to swell, and the limb should be flat, not elevated, because elevation decreases blood reaching it, thus aggravating the muscle ischemia. So keep the limb flat and monitor differential compartment pressure through pressure cath, and if it falls below 30, then immediate open fasciotomy is performed. If the differential pressure is still higher than 30 and there is strong clinical indicator for compartment syndrome. The patient has severe pain, paralysis, paresthesia, and the limb should be examined every 30 minutes interval, and if there is no improvement in the clinical signs for 2 hours, then the open fasciotomy should be done too. Sometimes pressure cath not available. Most developing countries hospitals don't have it, so diagnosis is even harder. The muscle die after about 6 hours, as we mentioned, so you need to take action quickly. And after fasciotomy, the wound should be left open and inspected 2 days later, and if there is tissue necrosis, then debridement is done and wounds sutured. And if the tissues are healthy, then sutured directly. Sometimes skin grafts are needed for the wounds to be closed. Now we will explain the fasciotomy of the leg. So fasciotomy is a procedure by which you open the fascia that covers the group of muscles together, the compartment. So you open the compartment fascia to relieve the pressure. And the leg is the most common area affected by compartment syndrome. That's why we will explain it here. And leg contains 4 compartments, and all has to be opened to relieve the pressure. So in the leg we have the anterior compartment here, we have the lateral compartment, we have the posterior deep compartment, which is here, and we have the posterior superficial compartments, which is here. And every compartment have multiple muscle and vessels and nerves. So general anesthesia is used, and here we will explain the double incision fasciotomy of the leg. There is another method using a single incision fasciotomy of the leg, and also there is different methods, different decompression methods for each of the limbs. So the forearm, the hand, the foot, everyone have different decompression methods. So it's double incision fasciotomy, so we have 2 incisions. The first one is the posterior medial, and the second one is the anterolateral. So basically we have medial one and we have lateral incision. The posterior medial is that we decompress the posterior superficial and the posterior deep compartments. So with this incision we decompress two compartments. They are the posterior superficial and the posterior deep. And it is through medial longitudinal incision 3 cm behind the posterior border of the tibia. And avoid injuring the saphenous vein and nerve by taking slow dissecting approach, and make incisions along the length of the posterior superficial and deep compartments to release them. Now the other incision is the anterolateral incision, and here we will decompress the anterior compartments and the lateral compartments, and with that we decompress all 4. So the lateral incision is placed halfway between the tibial crest and the line of the fibula, and you avoid injuring the superficial peroneal nerve, which has a variable course through the leg, by using a slow dissecting approach, and the anterior and lateral compartments are released by opening the fascia and intermuscular septum. Same goes with the posterior compartments. And with that we reach the end of this video. Thank you guys for watching. Please make sure to like and subscribe, and if you want to support more you can by subscribing to the Patreon, link provided in the description of this video. Thank you for watching, and peace.